This is Chapter 17, Labor and Birth Complications. When complications arise, the perinatal morbidity and mortality risk increase. Some complications are anticipated, particularly when mother is identified as high risk. Others are unexpected or unforeseen. Crucial for our nurses to understand normal birth process, prevent and detect deviations from the normal birth and labor, and implement nursing measures if complications arise. As stated, it is very crucial for the nursing team to understand the normal birthing process and prevent and detect deviations from the normal labor and birth, and implement nursing measures if complications arise. Also, the nursing and obstetric team must use knowledge and skills in a concerted effort to provide care in the event of any complications or emergency efforts. Preterm labor and birth. Preterm labor, cervical changes and uterine contractions occurring between 20 and 37 weeks of pregnancy. Preterm birth is any birth that occurs before completion of 37 weeks of pregnancy. Complications related to preterm birth account for more newborn and infant deaths than any other cause. Preterm birth and prematurity describes length of gestation regardless of birth weight. Low birth weight describes only the birth weight, 2,500 grams or less. It's easier to measure than preterm birth. Preterm birth is more dangerous. Intrauterine growth retardation is inadequate fetal growth. This is a picture depicting a low birth weight baby. Preterm birth versus low birth weight. Distinctly different meanings, often interchangeable. Preterm birth, length of gestation, and low birth weight refers to the weight at the time of birth. Spontaneous preterm birth, an early initiation of the labor process, comprises 75% of preterm births. Indicated preterm birth, a means to resolve maternal or fetal risk. Indicated preterm birth accounts for approximately 25% of all preterm births, and it is indicated because of the medical or obstetrical condition affecting the mother, fetus, or both. Risk factors for spontaneous preterm birth. History of spontaneous preterm birth, African American race, genital tract infections, multifetal gestation, second trimester bleeding, or low pre-pregnancy weight. These are all risk factors for spontaneous preterm births. Page 442, there are two boxes located in this chapter. Predicting spontaneous preterm labor and birth. Fetal, fibronectin, and cervical length. Causes of spontaneous preterm birth could be infection and bleeding at the site of placental implantation. See page 443 in your textbook. Prevention. Preventative strategies to address risk factors, health promotion and disease prevention, preconception counseling, interventions to prevent spontaneous preterm birth, and more research is needed. Early detection of those at risk, evidence-based practice, smoking cessation programs. Smoking has been linked to preterm and low birth weight babies. Identify and educate the family, the mother. Preterm birth can be prevented in some women by administering prophylactic progesterone supplementation and daily vaginal creams and weekly IM injections if needed. This is done in women with a history of prior to preterm births. Early recognition and diagnosis. Gestational age between 20 and 37 weeks. Uterine activity such as contractions. Progressive cervical change. Patient education regarding any symptoms of uterine contractions or cramping between 20 and 37 weeks. The woman must know that the diagnosis of preterm labor is based on three criteria. 1. Gestational age between 20 and 37 weeks. 2. Uterine activity. And 3. Progressive cervical changes. Effacement of 80% or cervical dilation of 2 centimeters or greater. This information is in your textbook, page 445. Lifestyle modifications have to take place, such as activity restrictions, restriction on sexual activity, and home care modifications. Suppression of uterine activities. Medications such as tocolytics to suppress uterine activities such as magnesium sulfate, terbutaline, and indomethacin. We want to promote fetal lung maturity. Antenatal glucocorticoids will help do this. National Institutes of Health recommend for all women at risk for preterm infants receive antenatal glucocorticoids administered between 24 and 34 weeks of gestation. Single course of antenatal glucocorticoids are given. Optimal benefits occur within the first 24 hours. It's given IM. It does stimulate the fetal surfactant production, considered one of the most effective and cost-efficient interventions for preventing morbidity and mortality associated with preterm labor. When labor progresses to cervical dilation of 4 centimeters, it's likely to lead to inevitable preterm birth. Max sulfate is given to reduce or prevent neonatal neurological sequelae. Malpresentation is common. Neonatal resuscitation may take place, and fetal and early neonatal loss may take place. It's recommended that max sulfate be given to women who are at least 24 weeks, but less than 32 weeks gestation at the time of birth is expected to occur. Breech presentation often occurs, and the nurses present must be prepared to handle emergency birth. Rupture of amniotic sac and leakage of amniotic fluid beginning at least 1 hour before onset of labor at any gestational age causes high risk for infection, chorioamnionitis, inflammation of the membrane surrounding the fetus, also risk of placental abruption, retained placenta, and hemorrhage. Preterm premature rupture of membranes, PPROM. Membranes rupture before 37 weeks of gestation. Approximately 10% of all preterm births. Infection is a major risk factor. Pathologic weakening of the amniotic membranes. Causes are inflammation and stress from uterine contractions. PROM is premature rupture of membranes, determined for each woman based on an estimate of risk. Infection is the greatest risk. Labor will likely be induced. PPROM is the preterm premature rupture of membrane before 37 weeks, managed conservatively and usually hospitalized. Increasingly seriously problem for pregnant women, likely, obesity in pregnancy increases a serious problem for pregnant women, likely to begin their pregnancy with pre-existing conditions such as hypertension and diabetes, increased risk of post-state pregnancy complications. Nursing care has many challenges in the pregnancy with obesity. Obesity is a BMI greater than 30. Version is the turning of the baby, externally or internally by the physician. You can see this on page 460 in your textbook. Induction of labor is the chemical or mechanical initiation of uterine contractions before spontaneous onset for the purpose of bringing about birth. The Bishop score is a tool used to ensure inducibility. 13-point scale. A score of 8 or greater on this scale indicates inducing labor is usually successful. This information is found on page 461 of your textbook. Cervical ripening methods such as chemical agents, prostaglandins, mechanical and physical methods, alternative methods such as blue cohosh and castor oils, evening primrose, and acupuncture are also used, and amniotomy. Oxytocin is a hormone normally produced by the posterior pituitary gland. It stimulates uterine contractions, used to induce labor or augment a labor progressing slowly because of inadequate uterine contractions. The use of oxytocin can present hazards to both mom and baby: placental abruption, uterine rupture, unnecessary cesarean birth due to abnormal fetal heart rate patterns, postpartum hemorrhage, and infection. The goal of oxytocin is to produce contractions of normal intensity, duration, and frequency while using the lowest dose of normal medication possible. This information is on your textbook, page 465. Oxytocin is a high alert medication. It can cause placental abruption, uterine rupture, unnecessary cesarean birth, postpartum hemorrhage, infection, fetal hypoxemia, and acidemia. Augmentation of labor is the stimulation of uterine contractions after labor has started but progresses unsuccessfully. Augmentation of labor is the stimulation of uterine contractions after labor has started but progress is unsatisfactory. Implemented for management of hypotonic uterine dysfunction, common augmentation methods are oxytocin infusion and amniotomy. Forceps-assisted birth. Maternal indications would be a prolonged second stage of labor. Fetal indications would be abnormal fetal heart rate tracing or certain abnormal presentations. Instrument with 2 curved blades is used to assist in the birth of the fetal head. The cephalic-like curve of the forceps commonly used is similar to the shape of the head. This picture depicts different shape and sizes of different types of forceps. This picture depicts a forceps being used on a baby's head. This is a video you can click on and watch of a forceps delivery. Vacuum-assisted birth. The attachment of a vacuum cup to the fetal head using negative pressure to assist the birth of the head of the baby. Prerequisites: completely dilated cervix, engaged head, vertex presentation, rupture of membranes, and no suspicion of CPD. CPD is caput molding. The woman is encouraged to push as pressure is applied. If vacuum extraction is not successful, a forceps or cesarean delivery is usually performed. This picture depicts a vacuum-assisted birth. Cesarean birth. Transabdominal incision of the uterus preserves life or health of mother and her fetus. Indications: elective cesarean birth, surgical techniques, vertical or transverse. If a cesarean birth is performed, the loss of experience of giving birth to a child in the natural manner may have a negative effect on the mother. The focus should be placed on the birth of the baby and not the surgical procedure. There are a few absolute indications for cesarean birth. Most performed for conditions that may pose threat to mother or baby. Elective is a cesarean birth performed without a medical reason. Reasons are fear of pain of childbirth, fear of sexual dysfunction. See this in your book, page 469. This picture depicts different types of incisions for cesarean birth. A is your vertical presentation and B is horizontal. Under cesarean birth, we need to discuss forced cesarean birth, complications and risk, anesthesia, scheduled cesarean birth, unplanned cesarean birth, prenatal preparation, and perioperative care. This information is in your text, page 471. We will discuss this in class. Woman having cesarean birth and intraoperative care involves positioning the mother so that she does not compress her inferior vena cava. The mother can have her partner present if possible. Immediate postoperative care involves placing the mother on a cardiac monitor, monitoring her vital signs, airway, and assessing any emergency protocols if needed. Postpartum care involves also assessing the surgical site, but also remembering that she is a new mom, and also taking care of her pain needs, and continuing to assess and massage the fundus and making sure that there's no hemorrhage present. Vaginal birth after cesarean, VBAC. Indications for primary cesarean birth such as dystocia, breech presentation, or fetal distress often are non-recurring, may be a candidate to attempt vaginal birth. Trial of labor, TOL, observation of a woman and her fetus for a specified length of time to assess safety of vaginal birth. You can find this information on page 475 of your text. Thank you, and this is the end of Chapter 17.